The hospice movement began with a woman named Cecily Saunders in the suburbs of London in 1967. Cecily was a physician, nurse, and social worker who opened the first hospice, named St. Christopher's. The modern-day hospice movement, as it is known now, started in the United States in 1974 with the opening of a dedicated unit at Yale New Haven Hospital, located in Connecticut. This movement started in an effort to meet the needs of terminally ill people that were previously unmet. The biggest impact on the movement was made in 1983 when the Medicare hospice benefit was enacted. This has led to the presence of more than 3,000 hospice programs throughout our country, and some form of services are now available in all 50 states. The Medicare system crucially impacts the care received by hospice. These benefits provided to recipients cover the costs corresponding to the qualifying terminal illness or its symptoms that are being managed. The goal of hospice is to utilize an interdisciplinary team whose main focus will be the recipient's comfort, enhancing their quality of life, and ensuring that they are treated holistically. It is appropriate that the mission statement of the local hospice is dignity, comfort, and peace at the end of life.
Hello, thank you for meeting me.
Hi, how are you? I'm a nursing student. My name's Winifred, but you can call me Winnie.
Okay, my name's Evelyn. I've been a hospice nurse for around 3 years now. Before we get going though, how much do you know about hospice?
Well, I do know that hospice is for care of patients who have terminal cancer, and this can be carried out in like a hospital setting or home setting depending on what the patient and their family desires as care for their last couple months of life.
Okay. We do get a lot of terminally ill cancer patients. However, hospice also outsources to like any terminal illness that has a prognosis of 6 months or less for life expectancy. We also have patients that have like end stage COPD, end stage like Alzheimer's dementia patients, end stage renal failure. So really any terminal illness where you have a prognosis of 6 months or less to live can be acquired through like hospice services. You qualify.
Oh, that's pretty cool.
And usually it's two physicians that refer. Like the patient's main physician can refer their patient to hospice, and then hospice has their own physician that's educated in pain management and death and dying process. So once those two physicians come up with the same prognosis of 6 months or less to live, then we can start the enrollment phase of the patient on hospice.
Oh, that's pretty cool. So because they're in their stages of life, they can't receive any treatments like chemo or
nothing that prolongs life. You're correct. Like with chemo and dialysis, those stop once a patient is admitted to hospice.
Okay, so it's pretty much just focused on like pain management and stuff to minimize.
At hospice, we look at patient holistically. We have cultural and spiritual chaplains on the hospice team. We have nurses, hospice care physicians, social workers to help with anything that the family or patient may need. We have our own stock room where I can bring extra wedges for prompting. We have standing orders, so if someone needs to relieve pressure in their bladder, I can insert a Foley through my standing orders through the physician.
Okay.
We also do respiratory care treatments. If someone's having trouble breathing, we can coordinate with the doctor and physician and get a patient on like a regimen of regular breathing, help with breathing. So it's more of looking at it as a holistic approach to the death and dying process for our patients.
Okay, so what kind of like how is somebody qualified for either like at-home hospice care or the hospital? Like how is that decision made?
We like to give the patient sole control over their end of life care as much as possible.
Okay.
And they can choose, let's say a patient decides to die within the home and they have end stage renal failure, but they acquire pneumonia. They have the choice to go to the hospital and get treated for the pneumonia, and it's strictly based on their choice. Like they don't have to go through treatment of another illness. It's completely up to them. And if they do choose to go to the hospital, our own physician, hospice physician, coordinates that with the hospital. And we still have hospice nurses that go into the hospital to meet with the patients. For Medicare and Medicaid guidelines and other private insurances, we get a referral within 48 hours of a referral for a patient. We have to see that patient and do an initial like home intake. Sometimes it can be sooner if it's an urgent matter. And then other sessions, like every 2 weeks, a nurse has to see that patient in the home or in the hospital to evaluate and see how they're doing.
Are there like other facilities where a patient can like live there for their end of stage?
There is. Unfortunately, in our area, we don't have those facilities. I know Vermont has a live-in home hospice facility, which is great. It's staffed 24/7. Patients, it's pretty much like living at home for the patients, and also like the social interaction, emotional support, because it's such a prominent piece of someone's life, the death and dying process, to be able to have that support, and families can come and go as they please. But in our area, we don't have that, unfortunately. So if they choose to stay in a home, we can't be there 24/7, and we can't staff it with aides 24/7. But we do have hospice aides that can go in like a couple hours a week to help with ADLs, positioning, and they can relate to the hospice care team of what they evaluated and what they've seen, and then we come in and help more.
Right. So like if a patient chose to stay at the hospital, they would have to abide by the guidelines of the hospital, like you know what their diet would be and stuff. But if they chose to stay at home, they pretty much have more control over their...
And I feel like it's more of like a comforting thing. Like some patients, believe it or not, actually choose to go to die in the hospital because I've noticed that pain management is a big priority, which it should be. It's a painful experience. However, they feel in the hospital their
needs are going to be met
more frequently for pain management. There's doctors there's physicians and nurses that their pain will be controlled. And also, versus at the home, like we've had patients that have had terminal lung cancer, but still feel the need to smoke and want to smoke. So it's a lot of it is also education. Like if they're on oxygen, make sure you remove your oxygen.
Right.
Try to smoke outside if you can, away from the oxygen tank. So it's pretty much about preference.
Okay.
And we promote the independence aspect of it.
Awesome. So like what happens if somebody were to decide to stay at home and they passed away? How would the family handle? Like would they have to call an ambulance service to come pick them up, or like how does that work?
No, they wouldn't call the ambulance. They would call us. We're on call 24/7, and then we come into the home and we can pronounce death, and then we can coordinate with them for funeral arrangements and everything.
Okay. So who are we seeing today?
We are going to see Peggy Barrett. She was referred to us the other day by her physician. She has end stage, let me just check my notes here, end stage COPD. She is a former smoker, widowed, and she currently lives in a home with her sister and daughter who are helping her with her care. So we're just going to go in and do an initial assessment, see if there's any concerns or anything they didn't get through the initial referral process, and just see if we can help out and see how she's doing.
Awesome. All right.
Coming.
Hi, I'm Evelyn, the hospice nurse. I have a student nurse with me. It's okay if she follows me around today.
Ellen. This is my aunt Claire.
Hi, nice to meet you. We spoke on the phone earlier.
Yes. Hi. Right, my mom's right in the back room. We can head this way.
Okay.
Mom, wake up. The hospice nurse is here.
Hi, I'm Evelyn. Nice to meet you. I have a student nurse with me today.
Hi, my name's Winnie. Nice to meet you.
Would you like to be called Peggy, Peg, or
Peg.
Miss Pratt? Peg? Okay, we do that. So I know I spoke with Claire the other day, and Ellen. But I know you already did like the first initial hospice interview and everything. But I just want to know if there's any other questions you might have that weren't answered, or any more concerns.
How are we going to pay for this? My husband died a few years ago.
I told you not to worry about that, Peg.
Oh, no,
We'll
it's
take
fine.
care of it.
That's a common question we get. I actually have this form right here. Yeah, this is the one.
Okay.
Due to your insurance, you have Medicaid. So Medicaid covers hospice services, so you would pay nothing out of pocket. We do have some hospice patients that do private payment for hospice, but you're covered.
So
So
nothing
hopefully
to worry
that
about.
relieves some concerns you may have about costs.
Definitely. Will my mom ever have to go to the hospital again?
Under hospice care, that's your choice. You don't have to go to the hospital if you don't want to. Some patients, like it's like say you develop pneumonia or something else that deems you more ill, that's not related to your condition. You can elect to go to the hospital, but you don't have to. And I can explain more to Ellen and Claire later about what that entails, but it's strictly your choice. You don't have to.
I'd rather stay here.
Yes, we know you would.
Well, you have a lovely home, and I admire your jerseys.
Go Canadians.
Oh,
I don't really watch hockey, so.
Me neither.
So, how have you been feeling lately? Any problems or concerns going on?
I've been tired and pretty short of breath.
Short of breath? Okay, what are you doing when you experience a short of breath?
Nothing.
Nothing? You're pretty much at rest or sitting in a chair, watching TV maybe?
Yeah.
It just comes on suddenly?
Mm-hmm.
Okay. Do you have any respiratory treatments that you do, like inhalers have you used now or in the past?
I think I had a few inhalers, but they don't really work as well as they used to.
We can look into different respiratory treatments and see if they could provide, she could schedule or order any new medications that you would like to try and see if that improves your breathing.
I think that would be helpful. They seem to work when she did have them, and then they decreased in effectiveness.
And well, whenever she orders, I can come into the home again and demonstrate the proper use and when and you should be using them and how often, and I'll leave you with a standard of care. So in case you have any questions, you can always certainly call me or the hospice center. But just so I list the instructions to you, like how to properly clean and administer medication if you're unable to.
Okay. Thank you.
So with that, then because you're short of breath at rest, how are you about walking around? Like, do you use any assistive devices or
I walk with a walker.
with a walker? Okay. And are you using that regularly, or are you more active during the day?
Sometimes I don't use it and use the furniture, but I'm afraid of falling.
Afraid of falling? Okay.
Yeah, we've told her to use that walker, but sometimes I'm afraid when she's even using the walker that I'm not going to be able to catch her.
Gotcha. Okay. We have a stock room at the hospice center, and I'll just make a note. I'll bring by some gait belts, and it's just a belt that goes around your waist, and then you guys can walk with her. If you feel like she's weak, I can demonstrate the proper way to lower someone to the floor.
Okay.
We'll work on that. So I'll just make a note right here.
I do have another question for you. She's really worried about her pain control here. Yeah, what can we do?
That's a common concern. Are you in any pain, experiencing pain recently, or
My chest and my throat hurt.
chest and throat? Okay. What have you been taking?
Uh,
Anything to manage it? Are you prescribed anything?
I think over-the-counter Tylenol.
Over the counter? Okay, extra strength, or this is extra strength?
Mm-hmm.
And how many times a day are you taking?
5.
5
6.
times? Okay, well, that's a higher dose than we like to see. You gotta be careful because recommended max usually is 3,000 milligrams per day. So you're right now exceeding that dose. So I'm gonna call Dr. Kelly and see if she can put an order in for something right stat so we can get that under control. Are you in any pain right now from a 0 to 10, 10 being the worst pain you ever felt, 0 being absolutely nothing? Or
A 6.
a 6? Okay. And that's not tolerable for you?
No.
Okay. Have you taken any Tylenol today?
Yes.
Okay. Do you know how much? Have you taken one dose of 1,000 milligram?
Yes.
Okay.
A few hours ago, I'm probably due for another.
A few hours ago? Okay. You can have that there. So I'll see if she can order something right now then. What pharmacy do you use? I have down here Kinney Drugs.
Yes.
Okay. We'll send something there. because we don't want you to be in any pain. We want you to be as comfortable as possible. So it's good that you're telling me this so we can get this under control, because the amount of Tylenol you're taking is not good. You're exceeding the max dose. So we'll see if we can get you something stronger, get you more comfortable.
Thank you.
And with that said, I'm going to take your vital signs. I'm just going to listen to your heart, lungs, and blood pressure, and take your O2, and then I will go call Dr. Kelly.
Okay. Here, I'll get out of your way here.
Alright, all your vitals look good.
I'm really tired. Are we done?
We can be, yeah. If you guys don't have any other questions, or...
Actually, we do have a few more questions.
Okay. Is it okay if I talk to Ellie and Claire out there about whatever they have questions, and they can fill you in later?
Whatever.
Are you sure? Okay. If you need me or anything, don't hesitate to call.
Thank you.
You're
It was
welcome.
nice to meet you.
It was nice meeting you, and I'll let you rest, okay? And I'll talk to Dr. Kelly about that pain medicine.
Thank you.
You had some more concerns or questions you wanted to ask me?
We were wondering when the aide would be coming in.
The aid, I had my schedule here. I can check for you. Here it is. Emily will be here tomorrow at 2 p.m. and then Friday at 1 p.m. That's what I have her down for so far.
So she won't be here 24/7?
No, unfortunately, our hospice services do not provide 24-hour care. Other facilities, I've heard do, hospice care centers and hospice homes, but unfortunately, we just don't have those resources in our area. Why is care going to be a concern, or is it a problem?
I don't think that's going to be a problem.
I feel like it's gonna be hard.
But Mom wants to stay home. I think we can help her.
Okay. Here's what I can do. I can look up for a list of organizations that could refer you to possible private home care. I have referred people in the past, and they have been very pleased with services in our area that provide private home care. You might touch base, like it's going to be like an out-of-pocket cost, however. Some organizations do provide some limited volunteer aids that they might let out. So I'll just make a list of referrals to organizations that may be able to help.
Yeah,
We
I
do
definitely
that.
think that's something to look into.
Okay. I want to leave you each with a pamphlet. These are a list of contacts of all important contacts that you may need.
Okay. Thank you.
You're
It
welcome.
was nice to meet you guys.
Thank you for
Bye.
coming. Drive safe.
As we face death, what are our rights as human beings? The following Bill of Rights was created at a workshop on the terminally ill patient and the helping person, sponsored by Southwestern Michigan Insurance Education Council and conducted by Amelia J. Barbas. The Dying Person's Bill of Rights. I have the right to be treated as a living human being until I die. I have the right to maintain a sense of hopefulness, however changing its focus may be. I have the right to be cared for by those who can maintain a sense of hopefulness, however changing it may be. I have the right to express my feelings and emotions about my approaching death in my own way. I have the right to participate in decisions concerning my care. I have the right to expect continuing medical and nursing attention, even though cure goals must be changed to comfort goals. I have the right not to die alone. I have the right to be free from pain. I have the right to have my questions answered honestly. I have the right to not be deceived. I have the right to have help from and for my family in accepting my death. I have the right to die in peace and dignity. I have the right to retain my individuality and not be judged for my decision, which may be contrary to the beliefs of others. I have the right to discuss and enlarge my religious and/or spiritual experiences, whatever these may mean to others. I have the right to expect the sanctity of the human body will be respected after death. I have the right to be cared for by caring, sensitive, knowledgeable people who will attempt to understand my needs and will be able to gain some satisfaction in helping me face my death. Someone needs to tell me how to run this.
I was gonna try to wake you up, but I couldn't remember your name. Yeah.
Any problem with incontinence?
No.
No?
Well, sometimes she doesn't.
We have respiratory treatments that they can do, like sometimes like iPrat, albuterol, and it's like a machine and it's just, you can use a mask, or sometimes it's pipe.
Okay.
All your vitals look good.
Are we finished? I'm really tired.
Right after the breast exam. Alright, good.
Peggy, roll over. Time to check your prostate.
Any pain more pus there?
Feel it?
Alright, well all your vitals look good.
You started talking?
No, go.
Oh.
She said cut so you would know when to start.
Pick your head up, Woody.
Like she could be there and just be like, "Excuse me, can I?" Well, would that be unacceptable? Would you ask somebody to use their restroom?
Yeah, probably.
Two further.
I have some other facilities that can, like Office of the Asian might be able to help you.
Office of the Asian.
The Asian, they do. They all plagiarizing me. I mean, patronizing me.
No plagiarizing.
And also, if you have any other concerns about management care, don't feel free to hesitate to call us.
Is that the money jar right there?
Yes.
So this is our hospice.
Oh.
presentation.
Deanna! Deanna, you're driving me insane.
That's Dina!
Poor Deanna! Deanna, stop laughing!